I have to share a story. We have a wellness center at the Cleveland Clinic, and one of my patients with Cowden syndrome participated in this Lifestyle 180, and it's mindfulness, exercise, plant-based diet, a variety of things that went into it. And so the first time I saw her, she had 180 colon polyps. The next year I saw her, she was down to 26, and I didn't take 150 out. And I said, "You look great." Well, before I looked in her colon. "Did you lose weight?" She said, "Forget the weight." She said, "I feel great. My CRP is down, my cholesterol's down, I'm off my blood pressure medication." She did lose some weight also. And when I saw 26 polyps, I said, "Who did you see between last time and now?" She said, "No one. I'm on this Lifestyle 180. So it's all about, you know, good health and wellness promotion through diet, exercise, and lifestyle." And the next time I saw her, she looked like hell. And I said, "What's going on? You look terrible." She said, I had my double mastectomy, I'm feeling like crap. And she was back up to about 173 polyps. And she had fallen off the bandwagon of exercise, lifestyle, just the wellness path that she was on. So there are some medications that can help reduce some polyps, although there's not convincing randomized controlled trial data. But don't underestimate the importance of wellness and lifestyle in mitigating the disease manifestations. So yes, 1 year would not be unreasonable.
Another question. So on the capsule endoscopy, they saw what they said were ulcerations. Can you get those SSPs in the small bowel?
The most common report that I get from outside physicians that are sending people to me are duodenal adenomas, and they look like they're very small, and an outside endoscopist that doesn't know the disease states, this is mostly for FAP, says, and numerous small ulcerations throughout the intestinal tract, and those are duodenal adenomas. But there can be small ulcerations related to other diseases. So are you sure there's not? Celiac disease, Crohn's disease, use of Advil, Motrin, or other nonsteroidals. So there could be a variety of things. I don't think small bowel ulcerations is in the spectrum of Cowden's that I'm aware of now.
Okay, thank you.
Thanks. So you said 6 millimeter polyps or things that look funny. Is there like a document I could share with my doctor to summarize that and so give some guidance?
We will write one as soon as I get back to Cleveland. But so what you could do is Brandy Heal, so a bunch of us on Dr. Eng's team actually had published an article in a journal called Gastroenterology in 2010 that explains the manifestations in the intestinal tract and all the different polyps. But the approach has not been standardized in PTEN, but it has an FAP. So another document that I might recommend, and if you go to the website acg.gi.org, they give an approach to the polyp management of patients with a hereditary cancer syndrome that has a higher risk of colon cancer called FAP. So you might use that, and you and I can talk offline, and I can give my card because doctors call me all the time and say, "Hey, what do I do?" Yeah.
Hi. Coming from the perspective of a parent with a young son, what should we be looking out for to see, if he's got polyps, if that makes sense, just from, what should I be aware of? Because he's non-verbal, so he can't tell me if
Right, so there has been some work that shows that children, and I'm not a pediatric gastroenterologist, but children with Cowden syndrome, almost 40% will have some GI manifestations. So it could be that your son, if he holds his abdomen and rocks back and forth, certainly rectal bleeding, not eating, vomiting, weight is dropping off. But in most of the data that we've actually published and has been reviewed, the average, the earliest age of cancer is usually no earlier than 30-ish. There's been some younger cancers, 19, but that would be very rare. And the risk overall of colon cancer is quite low. But anything that makes you think something's not right, weight loss, rectal bleeding, holding the abdomen, change in bowel habits, those kind of things. And there is no recommendation to actually start at a very early age for colon cancer screening. But when I have patients that are concerned, it's always good to see your primary care, your son's primary care provider, or a pediatric gastroenterologist to just discuss your concerns.
Is the recommendation after age 40 to go to Q2 colonoscopies?
It is not. It's 35 and every 5 years unless you have polyps on the exam. And so if you have polyposis, it might be as frequently as 1 year. But if you have 1 to 2 small polyps, it could be 3 years. So it all depends on the size, number, and pathology of the polyps. But it doesn't get shorter as time goes on, except for what's on the exam itself.
But I thought I saw on Dr. Eng's slide earlier that it was Q2 after age 40.
I wasn't here.
That was not the original 8 years ago.
That was the NCCN, which I provided you today, was just updated in January of 2018, and Dr. Eng said that was from 8 years ago, so updated data. Yeah, there's been updated meta-analysis looking at the world's literature that have come out in 2014 and 15.
Okay, so every 3 should be sufficient depending on the findings.
Right, the NCCN says every 5 years. For the average risk population, it's 10 years, and the PTEN population has only a slightly increased risk of colon cancer, akin to if I had a brother that had colon cancer under the age of 60 or a big polyp. So it's every 5 years, no less frequently than 5 years, and earlier, depending on what's found on your exam.
Q3 for me.
Well, you and I can talk about what's on the inside of your colon. But it would be if you had polyps.
Thank you.
Yeah. There's one more question here. Was it answered?
To follow up on the question she just asked, you mentioned change in bowel movements for our young children that can't explain, and we're starting to see that with our daughter. And our pediatrician ordered an abdominal ultrasound, which came back normal. Would you still recommend we follow up with GI, or is the ultrasound sufficient?
In adults, we don't use abdominal ultrasound to visualize the colon. I know in pediatrics it's oftentimes used as a non-radiation method of evaluating some hollow structures, including the appendix, but I am not aware of data that shows it's effective in looking at polyps in the colon. Maybe they're just looking for feces within the colon. I wasn't sure what that utility is.
Why they?
Yeah, you might ask how the ultrasound is useful, and then the next steps. And so it might be prudent, if there's no other warning signs, is that if the change in bowel habits is constipation, a few-week treatment of constipation treatment, and if things don't get better, that is probably when you want to make the next step. Yeah. Thank you, everyone.
Thank you, Dr. Burke. So now we're going to talk about thyroid cancer risk and management. Dr. Joyce Chen is an endocrine surgeon at the Cleveland Clinic in Cleveland, Ohio. She went to medical school at sunny downtown State of Medicine in New York and completed her general surgery residency at Albert Einstein Medical Center in Bronx, New York. She continued her fellowship training in endocrine surgery at the Cleveland Clinic in 2009. She is an assistant professor of surgery and serves as the surgical director at the Cleveland Clinic Thyroid Center. As an endocrine surgeon, Dr. Shen's interests lie in the diseases of the thyroid gland. She also has a special interest in study of endocrine genetics disorders such as MEN, FAP, and PTEN. Welcome, Dr. Shen.
Thank you very much. It is such a pleasure and honor to be here, and I want to really thank Kristen and the PHTS Foundation for inviting me today. So as an endocrine surgeon, I operate mostly on the thyroid and the parathyroid glands, which are both located in the neck. And my interest in hereditary syndromes began early in my training, mostly largely due to the work of Dr. Eng and my mentor at that time, and my interest in these hereditary syndromes pretty much grew throughout my academic career. So I have a few goals for today's talk. First, I want to give you a little overview of the thyroid gland. What is it? Where is it? What does it do? Most of us know what it is, but I'll fill you in a little bit more. Secondly, I want to talk about thyroid nodules and cancers in the general population and some few facts, current facts as early as last year. And then I want to talk about thyroid diseases, both malignant and non-malignant, in the context of Cowden syndrome, or PTEN. And then we'll talk about the management and the treatment of these nodules and thyroid cancer. So what is a thyroid gland? Well, it gets its name from a Greek word called shield, because as you can see, the thyroid gland looks a little bit like the ancient Greek shield. And it makes sense anatomically because it lays right in front of the trachea or the windpipe, and it shields and it protects it. The hypothalamus and the pituitary gland, which are these two glands in the brain, control how much thyroid hormones are released from the thyroid gland itself. And in that turn, controls our metabolism, or how our body uses energy. So the thyroid gland has many functions. It regulates our heart rate, our breathing, our body weight, which most women talk to me about, how we control our temperature and our muscle strength, and so many other different functions of the body. The thyroid gland is located in the neck. Like I said, it lays right in front of the trachea or the windpipe. There's a right thyroid gland and a left thyroid gland that is communicated in between by an isthmus, so it's really one gland. If you could feel your Adam's apple, which is more prominent in men, it lays right underneath it. It is protected by a few muscles of the neck, and as you can see, it is by very few important vessels on the neck laterally, which is a carotid artery and the jugular vein. So thyroid nodules, which is an abnormal growth of thyroid cells that form a lump, is very common, mostly more common in women than in men. I would say about 1 out of 5 women will have something growing in their thyroid. So as you can see, some of you may have undiagnosed or diagnosed thyroid nodules at this time. Unfortunately, only about 5% of these nodules are detected on palpation because most of them are too small to be noticed by a physical exam. And although only about 5 to 15% of these nodules are cancer, which is good, thyroid cancer is the most common endocrine malignancy and the most rapidly rising incident cancer in women, and second in men as of last year. So in 2017, about 56,000 new cases of thyroid cancer were reported, which accounts for about 3.4% of all new cancer cases. And there's about 2,000 cancer deaths from thyroid cancer. So although the incidence of thyroid cancer is rising, the death from thyroid cancer has remained pretty stable. So as we know, I don't have to go over Cowden syndrome, but it does increase our associated risk of thyroid cancer, as you can see, as well as other organs that we've talked about. And although PTEN mutation positive is the ultimate diagnostic confirmation of Cowden syndrome, we can also use the ICC criteria to diagnose patients with PTEN. And as you can see in the major criteria of the diagnosis, thyroid cancer is listed, and benign thyroid lesions is actually a minor criteria. Now, as a clinician, it is so important for us to recognize patients with PTEN, obviously due to the frequency of these associated cancers, but also their inherent implications for thyroid screening. Of the Cowden syndrome-associated cancers, as we talked about, thyroid cancer has the earliest onset and has a second highest lifetime risk, about 35%, only second to breast cancer. The usual guidelines is to begin surveillance at the age of 18 or 5 years earlier, 5 years before the earliest age of onset in a family member. However, current studies have shown thyroid cancer in the pediatric population as early as 7 years old. So our current recommendations of the Cleveland Clinic is to have a surveillance or baseline thyroid screening ultrasound at the time of diagnosis, regardless of age, and then yearly after that. This is a study that was done recently at the Cleveland Clinic with Dr. Ang and our group of endocrine surgeons, which looked at the association of thyroid nodules and cancers in the Cowden population. And it was no surprise that there was an early onset and a very high prevalence of both thyroid nodules, which are non-cancer, and thyroid cancer in this population. And these are some of the findings that we saw. So, in more than half of our patients had goiters in the screening population, and about 40% had Hashimoto's thyroiditis. Now, Hashimoto's thyroiditis is an autoimmune process of the thyroid gland where the thyroid gland loses its function. So, it's also known as hypothyroidism. Thyroid cancer was found in about 20% of our population that was screened, and about 14% of a larger PTEN population that is part of a national it's a national study. And the median age of cancer was 35. Compare that to the general population, which is about 49. So how do we screen for thyroid cancer? Like we said, we screen at the time of diagnosis. So I've seen patients as young as 2 years old, which can be a little bit challenging. And because physical exam is not very reliable, we rely on the ultrasound, which is an effective, non-invasive, and a relatively inexpensive test. So about 30% of surgeons perform their own ultrasound, and I use it in very different settings. Mostly I use it in the clinic when I see patients in my office. As you can see, this lady is just sitting very comfortably on a chair, and the ultrasound is actually in the office, laying right next to the patient. I also use it to perform biopsies. Like I said, most of these nodules, you can't really detect them on physical exam, so we use the thyroid ultrasound so we know exactly what to biopsy. And I also use it in the operating room for preoperative management, where to make the incision, any new findings that I may not have seen in the office. These are all used in the operating room also. So I'm going to show you a few views of the thyroid gland here. So I put a lot of pictures up, hoping to make a little sense of this. So we measure nodules in 3 dimensions, and I've seen many reports where there's only one measurement, but technically we should be measuring these nodules in 3 different dimensions because the size and its growth really depend year to year. So we measure it first in the transverse view, where the probe is laying side to side. Does a pointer work on here by any chance? No, the mouse, okay, excuse me, thank you. There you go. So here's a normal thyroid gland. So here's the skin up here. This dark area is the muscles, called the strap muscles of the neck. And then here's the right side of the thyroid gland, the isthmus, and the left thyroid gland, and this round black spot is a trachea. So anything air and fluid will look dark on the ultrasound. This little blob over here is a carotid artery that lays on each side. So this is a very nice picture of a normal ultrasound. The thyroid gland has kind of this grayish texture, a grayish color, so a little bit lighter than the rest of the surrounding tissues. And this is a thyroid gland on the right side, and as you can see, there's an abnormal growth here. We also measure longitudinally, so this is an up and down view. So here's the top of the thyroid gland, bottom of the thyroid gland, and here's this abnormal growth in the thyroid gland. There are different types of nodules, so it's really important to characterize what they are because different size criteria will meet for different nodules. So the most common type and the most worrisome is what we call a solid nodule. As you can see here, this is a solid nodule on the right side of the thyroid gland. And as you can see, we call this a hypoechoic nodule. I don't know if anyone has ever heard of these or read about these nodules on your ultrasound. So we call it a hypoechoic nodule because it is darker than the rest of the thyroid parenchyma. So it's almost, it's more grayish than over here, which is regular thyroid tissue. This nodule is also solid, but it is what we call isoechoic because it has the same color as the rest of the thyroid gland. And like I said before, these important wordings important for us endocrine surgeons because there's different size criteria when to biopsy these nodules. And the hypoechoic one on the left is the most worrisome. Now this is another picture of a nodule here. As you can see, there's some solid spots here, and then there's dark fluid around it, which is filled with colloid, or just a protein in the fluid part of the thyroid nodule itself. So because it has some solid and cystic components, we call this a complex nodule, another little technical term that we use. And they tend to be even more benign, so we don't biopsy these until they're about 1.5 centimeters. So another thing that we look on the ultrasound when we image patients is it kind of gives us a clue of if this nodule will be malignant or not. So some of the things that we look for is irregular borders, hypervascularity, a lot of blood flow in the nodule itself, and some microcalcifications. Now, although not one specific criteria will basically rule in or rule out cancer, these are a little clue of when to biopsy nodules. So these are some of the things that we look at. When we do a fine neoaspiration biopsy, there are these this national criteria that we use called the Bethesda system for reading thyroid cytology. So when we aspirate the cells, we make slides and we send this off to the cytologist. This is the language that needs to be read. So sometimes I'll see a patient and they'll come out with a pathology report which really does not fit into this Bethesda system. Then it kind of gives me an immediate clue that their pathologist is not really up to date with current criteria in reading these biopsy reports. So this is the language that we use. Most of them are benign, thank goodness. And if that's the case, then we usually repeat an ultrasound yearly or 6 months to a year the first time and then yearly after that. I just skip non-diagnostic. Non-diagnostic means that I or the pathologist or whoever did the aspiration did not get enough cells. This happens a lot when we have a cyst or fluid, so we'll tend to repeat the biopsy itself. The benign category has about a 0.3% of negative, false negative rate, meaning that although it does come back benign, there's a small chance that it still is cancer. The atypical of undetermined significance, or also known as follicular lesion of undetermined significance, has about a 5 to 15% chance of cancer. And if that's the case, we tend to repeat the biopsy in about a 3-month time. Biopsying it too early because of the current inflammation that you just created because you're sticking a needle into the nodule itself, that could have false positive rates. So we tend to give it a little bit of time before we do the rebiopsy. The cyst for follicular neoplasm, that is a very frustrating diagnosis here. It has a cancer rate up to about 30%, and the only way to find out if it's cancer or not is to remove the thyroid gland, because they actually need the tissue itself, not the cells from the biopsy, to confirm if it's cancer or not. And the surgical procedure is either a lobectomy, or removing half the thyroid gland, or removing the whole thing. And that is a discussion that you'll have with your surgeon. Now, all the other categories here has a much higher rate of cancer, and usually we do a total thyroidectomy, and if there are lymph nodes involved, then we'll also resect the lymph nodes at the same time. I just want to demystify a little bit of what happens in our ultrasound room. I know it's a little, it's very scary for an adult to even come and see me, so I can't even imagine how it's like to bring your little child with you. So this is our usual office. We have a very comfortable bed. We have the ultrasound sitting next door, and on the right is just a cart filled with some of the materials that we'll need for a biopsy. And I like to do everything all in one shot instead of sending you home and then coming back for the biopsy. So we like to do this one-stop procedure here. Very minimal things that we'll need for the biopsy itself. We have a few needles. Now, I know that looks huge and scary, but the needle itself is very small. It's even smaller than the needle that you use for a blood draw, although the gun that we use for the biopsy itself looks a little scary. These things on the right, we make slides over here, and we put into this alcohol jar, and that goes off to the cytologist to be read. And this is what we call cytolite. They'll spin down the cells itself. It's another way to read the biopsy results. So, of course, I'm a surgeon, so I'm going to put some yucky pictures up there. So these are some of the lists of thyroid cancers, and the most common is papillary thyroid cancer, which has an incidence of about 70 to 80%, usually in the general population. It is the most common, unfortunately. It has the best prognosis. And there's different subtypes of papillary thyroid cancer. And follicular classical are the most common, fortunately, once again, and the best prognosis. And then there are some aggressive subtypes as listed there. Now, Flicka Carcinoma is also a well-differentiated cancer like papillary, and it has about an incidence of about 10%. And this is a type of cancer that is the most commonly associated with PTEN. Medullary, anaplastic, and lymphoma are some of the other types of cancer not associated with PTEN, and even less in the general population. So just going back to papillary thyroid cancer, once again, most common type, unfortunately, patients present with no symptoms. So like I said, only about 5% of these nodules are detected on physical exam. So how is the incidence going up? Well, one of the reasons is that most of these nodules are diagnosed incidentally on other imagings that you may have had, such as CT scans, MRIs, carotid duplexes. Now, this type of cancer spreads lymphatically, so like I said, when I do an ultrasound, I tend to look at the lateral neck lymph nodes also, because this cancer was spread locally, unlike follicular cancer, which is more common with patients with PTEN. If this does metastasize, it metastasizes through the blood, so you'll find it in your lung and your liver, but the chance of that is also very small or very rare, because thyroid cancer is an indolent cancer. It takes years, most time, for it to spread. So what is a treatment? Well, when you're diagnosed with thyroid cancer, the treatment is a total thyroidectomy, where we'll remove all of the thyroid gland and the appropriate compartment lymph node dissection. Now, there's no chemotherapy or radiation for thyroid cancer, but we have what we call reactive iodine treatment, which sounds scary, but it's not, where you will swallow a pill of iodine that is traced with radiation, and that will kill any leftover microscopic thyroid cancer cells that are still living in the neck. You can live without the thyroid gland, but you can't live without thyroid hormone. So I don't know if you've heard of the medicine Synthroid. Millions of people are on it. It's a pill you take every day for the rest of your life, about an hour before you have food or coffee, which can be very difficult in the young population. If you're diagnosed with thyroid cancer, whether you have PTEN or not, you will need long-term surveillance with ultrasound and blood work. So thyroid hormone replacement, we have to replace fully, and it's all based on your body weight. So if you're a young, healthy patient, you have about 1.6 micrograms per kilogram per day. And if you're a little bit older, where you don't